Good morning, everyone. I'm Dr. Tejaswini, and I work as an affiliate clinical lecturer with University of Adelaide. And recently, I got invited to TACON 2024 to deliver a talk on renal replacement therapy. Because I had put in a lot of effort in preparing the presentation, I thought it would be a good idea to just actually ensure that I present and record this for the benefit of intensive care trainees mostly. And as we all know, most conferences we end up going for networking, and it is impossible to attend all the lectures. So I thought it would be reasonable idea to upload this as a video and then maybe utilize it for teaching purposes in the future. Okay. So I will just start sharing the screen to begin the presentation. So renal replacement therapy. I will be dividing my presentation on these topics. First, we will begin with introduction, and then we will look at the types of renal replacement therapy. We will also touch upon the principles that are involved in renal replacement therapy. We will quickly look at the calculations, which will help us in improving the filter lives, and also in few important calculations which are necessary whenever a patient is on renal replacement therapy. Then we will address a few questions which are controversial with regards to renal replacement therapy. And I will also highlight the important evidence which is available in the literature. And this will help us make some conclusions during this talk. Okay. So I always start my talks with a brief overview of history, because I think history teaches us a lot of things. We will not spend time on repeating the same inventions. Also, we will ensure that we will not make the same mistakes. That is why we need to know history. So the history of renal replacement therapy is pretty interesting, because it first started sometime during World War One. And they tried to create an artificial kidney, mainly by looking at animal studies on rats. But then I think with the World War and everything going on, resources must have been tight. And eventually, during World War II, is when Dr. William Kolff, he is called the father of dialysis. He dialyzed the first patient in Netherlands who was admitted with acute renal failure and uremic coma. And this patient went on to live for another 7 years after this. So he is officially the father of dialysis, and he has done exceptional work around this, including his involvement in cardiopulmonary bypass machines and creation of artificial heart, all of those things. So ECMO, today's ECMO. So he has been instrumental in giving world renal replacement therapy. So this is the machine that he created to dialyze the first patient using a laundry tub and a washing machine motor and a washing machine drum. So it's pretty interesting. And this was the machine that he used in the year 1943. This was followed by another important invention by Dr. Golding Scribner. Scribner introduced something called Scribner's shunt, where he cannulated radial artery and a vein and then created this shunt for efficient dialysis to take place. This has now morphed into what we know as AV fistula. So this is also pretty interesting. The first dialysis in India actually happened in CMC Vellore in the year 1961. But that was done by Dr. William Kolff's team, which came from the US. Indigenously, dialysis was first done by Dr. P. Raghavan, who was actually a gastroenterologist at the KEM hospital. And he got the Alcoff machine and did dialysis on the first patient in India in the year 1963. And this is the machine that he used. Later on in the year 1977, Dr. Peter Kramer did CRRT for the first time using this setup. And CRRT today hasn't changed much. This is the machine that I have used in India and Australia, and this is how it looks. We will talk about the components of the CRRT machine, but just to give a brief overview, this is the filter, and there is a centrifugal pump, there is an anticoagulant syringe, and these are the bags. This is ultrafiltrate or effluent, and we have dialysate bags, replacement fluid bags, which are running. So this is a simple setup of the CRRT machine. that we know as of today. And what's in the future? With regards to CRRT machine, I don't think nothing much will change apart from the size of the computer that is regulating its function. But with regards to hemodialysis machines, there is a lot of emphasis on patients being able to mobilize wearing the hemodialysis machines and not getting, because they have to do it twice a week most often. So this is the newest machine which has been patented by China, and this is called a wearable artificial kidney. So this is what is possibly awaiting future. Now, with regards to the type of dialysis, there are two important major types that we can divide. The first one is intermittent hemodialysis, which most often happens on an OPD basis for renal failure patients. And the second one is continuous renal replacement therapy, which often happens in very sick patients admitted to the hospital. So, in hemodialysis, in intermittent hemodialysis, we have the regular one, which happens in the chronic renal failure patients. And we have something called prolonged intermittent renal replacement therapy, of which slow, low efficiency dialysis is one of the types. This is something of interest because this can be carried out in hemodynamically unstable patients in resource limited settings where it is not possible to run continuous renal replacement therapy. In continuous renal replacement therapy, we have something called slow continuous ultrafiltration, and then we have slow veno-venous hemofiltration, we have slow veno-venous hemodialysis, and the combination of these two is continuous veno-venous hemodiafiltration. This is what we commonly use in ICU. This runs over 24 hours. All the continuous renal replacement therapy runs over 24 hours, and it is quite labor intensive for the nurses as well as monitoring wise. But it is very efficient in hemodynamically unstable patients without causing larger fluid shifts or solute transfers, electrolyte transfers. So basically, all dialysis machines use either convection or diffusion along with some amount of filtration and adsorption. So all these four principles are used in different fractions to arrive at a modality of dialysis. The ones that we are interested for hemodynamically unstable, acutely ill, critically ill patients are SLED and the continuous veno-venous hemodiafiltration. I will talk about this a bit more. The biggest advantage is the low blood flows, which is feasible with both these modalities, which is 100 to 200 ml per minute. Whereas with intermittent hemodialysis, you need to use around 450 to 400 ml of blood flows. Okay. So the principles, as I said, there are four important principles whenever it comes to dialysis. The first one is ultrafiltration, which happens by pressure. So the physical principle regulating ultrafiltration is with pressure. So convection is one thing that governs ultrafiltration. The next one is diffusion. In diffusion, what happens is the solute moves from a region of higher concentration to a region of lower concentration. The biggest advantage of this is whenever the solutes move, there will be exchange of solutes to attain an equilibrium. So there won't be sudden drops in the solute concentration. So the second one is diffusion, which is commonly employed in hemodiafiltration. Okay. And then there is another concept called adsorption, where some filters are used to specifically adsorb certain toxic molecules. And this principle has been utilized in development of filters to adsorb toxins in septic patients. Okay, and then along with these principles, we will just quickly run through how these principles work in action. Okay, so first, as I said, filtration, where a solute and solvent, which is water molecule, both of these cross the semi-permeable membrane, and this is governed by pressure. So if you run through this, so this is how it happens. These are solute molecules and these are water molecules. They are governed by pressure and they cross the semi-permeable membrane and an ultrafiltrate will be generated. Now, in dialysis, what happens is the principle that is governing this is diffusion, where the solute moves across the semi-permeable membrane along the concentration gradient. So here there is blood which is going on one side of the semi-permeable membrane and there is dialysate fluid. Some solutes from the dialysate fluid move back to the blood and some solutes from that blood will move to the dialysate fluid. There will be movement of fluid as well along the semi-permeable membrane. So now moving on to, that is the principle that governs dialysis. Let us move on to the circuit, how the dialysis circuit works. So the patient will have a cannula, the vascat, which has a arterial port and a venous port, but they are both lying in the central venous circulation most often. So what happens is from the arterial axis, blood is drawn, an anticoagulant, either citrate or heparin is injected, and then it goes through a pump. And in from the pump, it reaches the hemodialysis filter where dialysis occurs. And then the filtered blood will return back. There will be a bubble trap to ensure that there are no air bubbles in the filtered blood. And then it is safely returned back through the venous access to the patient. This is how the hemodialysis filter works. Now, a bit more complex diagram, but I will try and simplify this. So we are talking about continuous veno-venous hemofiltration here. As I said, hemofiltration will involve movement of solute along with the fluid using the principle of convection in one direction. Okay. So that is pressure dependent. The effluent volume will be pressure dependent. So because large amount of fluids can get lost, there will be a replacement fluid that we need to utilize whenever we are utilizing hemofiltration. So blood from the patient, blood flows around 200 to 300 ml will go because these are pressure dependent. So blood flows are a little higher when compared to CBV HDF. Then an anticoagulant will be injected. Then it goes through a pump and reaches the filter. And then in the filter, either through convection and the solute along with the fluid will get filtered across the semi-permeable membrane. And then we will use a replacement fluid in the bubble trap and or deaeration chamber and return back the filtered blood to the patient. So filtered fluid needs to be replaced. The dose of this is the dose of replacement fluid is usually calculated based on the effluent rate or the ultrafiltrate, which will look at both pre and post dilution pumps and ultrafiltrate flows. What is pre and post dilution pumps? So pre and post dilution pumps are utilized to actually ensure that the filter doesn't clot. So if the patient's blood is too thick and dehydrated, then you might have to add some more volume to it to bring up the pressures and then run it through the filter, that is pre-dilution. And then there will be post-dilution. Sometimes if the dilution is too much or too little, or if there is too much of ultrafiltrate that is removed, then we use a replacement fluid to combat that, and that will be the post-dilution. So the clearance of middle molecules is fluid dependent on blood flows. So, okay. So I will try to explain what are middle molecules. So there are three types of molecules. One are large molecules, which are usually plasma proteins. And the second one are middle molecules. These are usually albumin, toxins, all of those. And the third one is smaller molecules, urea, electrolytes, all of these are smaller molecules. So what happens is whenever we are trying to dialyze using the concept of convection or ultrafiltration, middle molecules can be cleared faster and fluid also clearance is also dependent on the blood flows because these are pressure dependent. The next one is hemodialysis, continuous veno-venous hemodialysis. Again, in this, we have low blood flows when compared to ultrafiltration. We still use the anticoagulant, but once the blood enters the dialysis filter, the blood moves across the solutes move across the semi-permeable membrane in both directions. there is a countercurrent flow of dialysate which goes in the opposite direction as blood, and there will be movement of solutes to attain equilibrium. So this is very important when I talk about potassium calculations later. So this is diffusion, and then this filtered blood goes back to the patient. Here, again, this is how, this is the most important part of dialysis, hemodialysis. And the dose will depend on the dialysate flow as well as the ultrafiltrate flows. So here, clearance is independent of the rate of blood flow because it is going to be slow, efficient, because there will be movement of solutes, bidirectional movement of solutes to attain equilibrium. This will be independent of blood flow. Now, both these concepts have been incorporated into what we do in ICUs as continuous veno-venous hemodiafiltration. Here, we are using the same low blood flows of 80 to 150 ml per minute, and then after anticoagulant is injected, it goes to the dialysis chamber where there will be movement of solutes bidirectional with the concept of diffusion. And then we are using the dialysate fluid in the countercurrent fashion, but we are also utilizing the replacement fluid here, where filtered fluid will be replaced so that there is not much of hemodynamic instability. This is the most important aspect of CVV HDF, and that is why it is very safe in patients with hypotension and hemodynamic instability. So clearance again is independent of the blood flow in this. Now, quickly moving on to calculations. So